Where we're going with telemedicine is exciting, and I think it kind of brings this all together. And what we do is we do think about it as what are we going to be offering at a facility level, in the remote clinics, at the medical facilities, then what's going to be organized more at the network level and then more at the national level. And at the facility level, I think we're going to be doing a tremendous amount of services into the home. There's tons we can offer, and that's where it's probably most convenient for most people to get their care. Also at the facility, telehealth is just going to be integrated into our daily operations. And what does that mean is that probably every specialty is going to adopt some portion of remote care or virtual care to make their services more accessible. It's also just going to be a part of routine operations in the sense that when a veteran leaves a clinic appointment, there's going to be a question of how do we best deliver this next visit? Is it in person? Is it by telephone? Is it by video? So it's just going to be kind of part of the regular routine and thought processes. Also at the facility level, we're going to make care more accessible to families and caregivers. As we know, you get better care when you have someone helping you navigate a complex medical system, especially if you have a lot of comorbidities. Some of our elder veterans fit into that category. So being able to invite someone in and saying, yes, it's hard for you to make this appointment and help the veteran out, but we're going to bring you in virtually so you can attend the appointment, listen to the doctor, help them after they leave the clinic. That's really important. I mean, some family caregivers live, across state lines. We also want to enhance our remote monitoring program. I mean, obviously that's been very successful. We want to add more options. Right now, there's a certain threshold that people have to meet to get into that program. They have to respond every day. They, provide information. We need to have something, and we're going toward more of a continuum of services so that no matter where you are in your healthcare journey, there's some way you're going to be able to engage with us, and we're going to be able to engage with you to get services. So that's at the facility kind of medical center. When you look at the VISN or region, and this is where the cross-state line comes in, what we have in this country, in our VA system, but also in our communities, is there are certain places where there are just gaps in services. And this is where the legislation comes in. It's so critical to provide, is that we need to look and say, where can't you get a certain service in the VA? Where can't you get neurology care? And where also is that care not available in the community? And that's on the top of our work list. We need to figure out a program so we can remote in that care or do a hybrid model where we bring in some in person, some remote care. For primary care mental health, core ambulatory services, we need to expand our interim staffing program. This is where, again, at a site that's rural, you lose one of your primary care providers. We don't want to wait 6 months to a year to get someone else in there. We're going to start hiring that provider, but we want to bring in a remote primary care provider to fill in those services so we provide consistent access. Similar at the regional level, we need to do consultant networks. If a provider, I'll speak to my own experience. I worked at a large academic site. I had a list of all the subspecialists that I could contact. When I needed help, I got help. If you're in a rural clinic, we can provide that same level of support for every provider that's sitting even in a one-doctor clinic. They should be able to go to an icon on their desktop and just say who's on call for cardiology, nephrology, pulmonary, be able to text them, email them, start a video, start a phone call. And it doesn't matter where that provider is sitting. That provider may be 2 states over at a large academic site. The point is the provider that's sitting out in the rural community needs to feel they have the entire organization at their back, taking care of the veteran in front of them. And at the national level, we need to have failover capacity. We need to make sure that when we set up our telestroke program, our tele-ICU program, that we do it in a way that if one network goes down, we have failover. We also need to move around our national experts. So if there's an expert in a rare condition, that person, let's say there's 10 veterans that have that rare condition, that provider is providing input into all of their care. And so I think when you look at that, you see, yes, right now a lot of it is, the decisions are made at the facility. It's facilities trying to take care of the veterans in their catchment areas. We're moving toward a model where we're doing more interstate, more across the VISN, but where we expect to go, we are going to leverage the VA enterprise in a way that you can't do if you don't have a national integrated healthcare system. And I think that's where it starts getting incredibly exciting.